Hey guys, Cody Warner with Idaho Medical Academy. Today we're going to be going over BLS Airway Management and how you could assist with some ALS airway management techniques as well. To get started, we'll talk about positioning the airway, we'll talk about suctioning, airway adjuncts, various oxygen delivery devices, CPAP, and then we'll start getting into our ALS airway management. So let's get to it. Okay guys, the first thing we're going to talk about is airway positioning. So one way we can position an airway once we come up to a patient, whether they're unconscious, we've already gone through AVPU, we've determined this patient is unresponsive, we now want to assess the airway. We want to see if the tongue is obstructing the airway or if there's any vomit or sputum in the airway that's obstructing our airway, so we want to open it. If we have no reason to believe that there's been a mechanism of injury, we can just do a simple head tilt chin lift. Looks just like this. I'm going to take the back of their head, I'm going to push it down. As I'm grabbing their chin, I'm going to pull up, just like that. This isn't forceful, this isn't aggressive, it's just really, really easy, and it's going to open their mouth to where now I can easily see in it. As you can see, it's a very simple technique, and you already see how much it opens the airway. With these mannequins, it's obviously a little bit easier as they are rubber and they grip to the plastic. On some patients, right, with hair or sweat or moisture, hardwood floors, things like that, this might be a little more difficult to maintain, so I might have to sit here and hold it. But yep, just one more time, head tilt, chin lift. If for some reason I am worried that there is a mechanism of injury, I'm going to do something called a jaw thrust. This is so I am not manipulating C-spine, right? With that head tilt chin lift, I'm now manipulating the neck. So if there's an injury here, I'm just causing further injury. But if I do a jaw thrust, you'll notice their head and neck stay directly in line. So I put my palms on the cheekbones, put my fingers below their jaw, pull up, and then I can push their jaw out. Again, this is probably easier on an actual person, but you notice the neck stays completely in line. And another point that I just want to make and get across is, obviously I'm doing this from the side just for the camera's view. If I'm managing somebody's airway, I'm always at the head. So it would look something like this. So if I was doing my head tilt chin lift, I can do this and look in the airway, or I can do my jaw thrust, which is much easier from the patient's head. Okay guys, now that we've talked about how to position an airway, let's start talking about suctioning. So say I come up to my patient, they're unresponsive, I'm going to do my head tilt chin lift and assess the airway. Say it's full of secretions, I have vomit, I have fluid, I have blood. If I start to use a BVM and breathe for this patient, I could be putting those secretions or that vomit into their lungs and causing them to aspirate. I could be trying to force it into the stomach, causing them to vomit even more. But at the end of the day, I'm not giving adequate breaths. So what I have to do as an EMT is now suction the airway. So I'm going to do my head tilt chin lift. I notice I have secretions in the airway. I'm going to now suction. So I'm going to get my suction kit out. Typically, you'll see it in some sort of bag or kit like this. Flip it open. You can leave your suction machine in the bag if you'd like. Some people will take it actually out of the bag. Find your on button and turn it on. For the sake of the video, we'll go ahead and just leave the suction machine off. Once you turn on the suction machine, you'll notice that you won't have any suction. It'll be on, but you won't have any suction. To actually create suction, there's a little hole on this, what we call a yank hour, a little hole that will cover, and then that's providing suction, okay? So we want to test our suction, make sure we actually have suction. Then we're going to go into the airway without applying suction. If I go in with applying suction, the tongue gets pretty floppy, or the cheeks might sink in a little bit, and I might catch the cheek, and I'm not actually giving suction. Or I might catch the tongue, and I'm not actually giving suction to the actual problem. That fluid is probably going to just sit right at the back of the throat. So I'm going to go in. Sometimes you might need a flashlight or have a partner hold a flashlight so you can see what you're doing. If you're in the back of the ambulance, it's usually pretty well lit. But I'm going to go in without suction, and I'm only going as far as I can see. I do not want to force this somewhere where I have no idea where it's going, right? I'm not going to go into the esophagus or try to get into the trachea. I'm only going as far as I can see, and then I'm going to apply suction. I'm going to suction on the way out, okay? You can do a circular motion. You can do a zigzag. One thing we don't want to do is we don't just want to sit here and hold it. We want to suction out because you might catch something on this, whereas you might need to actually come out of the airway, scrape it off, clean it off on a towel or something, and then go back in. So suction on the way out. Cool, our tip is still clean. I'm going to go back in without suction and continue to suction. We try not to do this more than 15 seconds. We don't want to deprive them of oxygen, but I'm not going to try to force a breath with a bunch of fluid. So just really do your best. Try to clear the airway. Yeah, and then start giving a breath once the airway is clear. Okay guys, now that we have our airway completely clear, we can now place an adjunct to assist in ventilating our patient. So as EMT basics, we have two types of airway adjuncts that we could use. We have an NPA, or a nasopharyngeal airway or adjunct. We also have an OPA, an oral pharyngeal airway or adjunct. OPA is pretty much used for the most part on most patients because they're simple to place, and if our patient has a gag reflex, we can take it right out. These do, as you can see, come in multiple sizes, so you have to choose the best size and measure before you place it in the patient's airway. If you use an incorrect size adjunct, you're actually not helping your patient at all. So I'm going to take this one, I'm going to measure it. When measuring for an OPA, I'm going to go from the corner of the mouth to the bottom of the ear. This one might be just a tad small, or actually it looks perfect. This one's going to be good for our patient. It doesn't matter what way I measure it, the OPA stays the same length. So we're going to open up our patient's airway with our head tilt chin lift, takes a tongue off the back of the throat, so we're already helping our patient. And now I'm going to place my OPA. I like to go at a 90 degree. A lot of people will do 180 degrees. But let's think about the anatomy of the oral pharynx. If I place this OPA like this, it's going to sit in here like this and give air up here. It's not going to fit at all. So I want it to sit like this when it's inside. So 90 degrees. I'm going to kind of scoop that tongue out of the way. I'm going to turn it and place it. Now my patient accepts. If my patient begins to gag or bites down on this OPA, I want to immediately take it out because I want to prevent my patient from vomiting, okay? But if not, we're good to just leave it in, and now we can start bagging our patient, and now this airway is protected, right? I have the tongue out of the way, the airway is open, they can't close it because my OPA is in the way, and I can start delivering breaths. The other thing we have is an NPA, or the nasopharyngeal airway. Again, these come in all different sizes, okay? Some patients have bigger nostrils than others, but we're going to measure it. So I'm going to measure from the nose to the bottom of the ear, okay? With these, there's a very specific way we want to place these. As you can see on the NPA, it has a bevel. That bevel is going to go towards the septum. Before I place this in my patient's nose, it has to be lubricated. Most departments or agencies will carry little packets just like this full of lubricant. Typically, I'm just going to take it, place it on my NPA. Don't need a lot. Our nose is so vasculature or has so many little capillaries that are very easy to damage, and we can actually cause a lot of bleeding. So if we're sticking this rubber in there, it's going to cause a lot of bleeding and a lot of harm. So if you can lubricate it, you're going to do your patient a favor. So that bevel towards the septum. One thing a lot of people will do as well is they place it in the nose and they think if they just push up, it will then just naturally go into the right spot. This is something I had trouble with a lot as a new EMT. One thing I figured out and how it works very well is that nair kind of goes down this way behind the oral pharynx. So we're going to push straight down, just like that. Again, this mannequin has perfect nostrils, so it's going to be a little more difficult on an actual patient. But if you can remember that rule of bevel towards the septum and placing straight down, patient should accept. Even if they have a gag reflex, they will most likely still be able to accept an NPA. So if they have the gag reflex, try an NPA. If they're still fighting that, you might just have to do your best with the head tilt chin lift. The other thing we can do is we can put it in the other nair. Still doing bevel towards the septum. So we're going to place it, and then as we're going into the actual nair, we're going to twist it 180 degrees, just like that. If you're an EMT basic and you're in charge of the airway, do not be afraid to place an OPA and 2 NPAs. This will control and manage your airway very, very easily and open it up very, very well and make actually delivering breaths much easier. So if you have the time, please go ahead and place 2 NPAs and an OPA. For our patients that are conscious and talking to us and are alert and oriented that need oxygen, we're not going to place an airway adjunct in them and start bagging them, right? We're going to assist them by giving them a nasal cannula or a non-rebreather. To do so, we have to set up our oxygen or our oxygen tank. With this, we're going to have our tank, we're going to have our regulator, and we're going to have an oxygen wrench, okay? So when doing this, we like to crack our tank, make sure we actually have pressure in the tank. And we're going to place our regulator on the tank. We're going to open our tank, make sure we have pressure, which we have about 1,000 PSI right now. These bottles hold up to 2,000, need to be refilled at 500 PSI. To control our oxygen flow, we're going to use this dial right here, and it has little numbers on it so we know how much we're giving. Okay? So the least aggressive oxygen delivery device we have is going to be our nasal cannula. You probably see this on a lot of elderly patients, patients who just need a little bit of oxygen in their day-to-day life. Very easy to use. We typically flow this between 1 to 6 liters per minute of oxygen. So this will go in the patient's nose, and then we connect it to the oxygen right here. And if I want to put it at 4 liters per minute, I change it to 4, and then our patient can now inhale that oxygen. The other O2 delivery device we have is a non-rebreather. This is for our patients who, you look at them and you can tell they're having a lot of difficulty breathing. They're tripoding, they're having 2 to 3 word sentences, their oxygen sats are very, very low. And we really want to be aggressive with non-rebreather. Typically in the field, we throw on a non-rebreather when we think our patient is what's called circling the drain, or we might be having to intubate this patient. We like to pre-oxygenate them with a non-rebreather because this has a lot of oxygen in it. So with the non-rebreather, we're going to flow this at 10 to 15 liters per minute. So I'm going to change my dial. Right now we're at 10, and you guys will see this bag starts to inflate. So I want to make sure this bag is completely inflated or full of oxygen before I place it on my patient's face. So now, okay guys, now we'll demonstrate placing a nasal cannula and a non-rebreather on an actual patient. Hi Wade.
Hey Cody.
Okay, so when placing a nasal cannula, it's going to come in this pre-package. We're going to open it up. I've already set up my oxygen regulator, my oxygen tube. I'm going to connect this to my oxygen. I'm going to place it at 2 liters per minute for now. If I need to give him more, I will give him more. So one thing we see in the field a lot with somebody who's doing this for the first time, they look at this. This is going to actually loosen this little tab here and tighten. But one thing we see a lot of is they try to go around the patient's head like this. This is actually incorrect. So what we want to do is we want this to sit around the patient's ears and that be in their nose, this part be in their nose. So one thing I do first is I take it, place it in my patient's nose, and then I come around the ears like so. And now I can actually tighten it. And now my nasal cannula is placed. Okay. For the non-rebreather, again, we're going to take our new non-rebreather. I'm going to open it. Sometimes the tubing's connected, sometimes it's disconnected. Currently it is connected. Get the tubing. I'm going to unfold my reservoir bag. Make sure I have an adult mask for my adult patient. I'm going to place this on my oxygen regulator. Again, this is going to be flown at 10 to 15 liters per minute. I'm going to start it at 10, and if I need more oxygen, we'll go up from there. I'm going to make sure I pre-fill my reservoir bag. I'm going to place this on Wade's face. Sometimes patients can be anxious, so I'm going to say, hey, just like a mask, go ahead and take some nice, slow, deep breaths. Place the mask on, place the band just above his ears, and now I can tighten it and use this metal brace to form it to his nose, and now this fits perfectly on my patient. Previously, what we talked about with the oxygen delivery devices of the non-rebreather and the nasal cannula, that is oxygenating our patient, right? Our patient is ventilating on their own. They are actively breathing. We can see them pulling air in and pushing air out. But when we take their vitals or we look at their skin, they are not perfusing. They're pale. They might be cold. They might be clammy. We put on our SpO2 monitor to actually read the oxygen saturation, and it could be very, very low. They're breathing, but they're not being oxygenated. So we're going to oxygenate our patient with the non-rebreather or with a nasal cannula. Now, when we come to a patient like this, we do our AVPU, right? Sir, can you hear me? Hello, hello, hello. Okay, they're not responsive. They have a pulse, but they're not breathing. This chest is not moving up and down. So if I put a non-rebreather on this patient or I put a nasal cannula on this patient, it's doing nothing for my patient because that oxygen isn't going anywhere, right? They're not ventilating, okay? So if my patient isn't breathing, I now need to ventilate them. Same science though, if I ventilate them without attaching them to oxygen, I'm giving them atmospheric air, and this patient needs a lot more than that, right? So we're going to place them on oxygen, and we're actually going to use a BVM to ventilate the patient instead of just oxygenate them with a nasal cannula or a non-rebreather. So getting into the BVM, right? We've opened our patient's airway, we've suctioned, we've placed our adjuncts, our airway is maintained, and now we need to start ventilating. So we're going to pull out our BVM. Typically, it is all put together just like this, as you can see. Sometimes your O2 tubing might not be connected on the back. This one looks to be permanently connected, so you can't forget it. But this, once we hook this up to oxygen, this oxygen is now going to feed into this BVM to where we squeeze. We're going to have oxygen coming in. Once this fills up with oxygen, it's going to backflow into this. Like with the non-rebreather, we have to pre-fill that reservoir bag. With the BVM, we do not have to. So place it on oxygen and begin delivering breaths. In a lot of departments, a lot of protocols, it is acceptable to give a breath with our atmospheric air, then plug in to oxygen and continue giving breaths. So with the BVM, we like this at high flow. If we flow this at 2 liters, at 3 liters, it's not going to be enough to fill that BVM up. So we want to put this at 15 liters per minute every single time. 15, as you can see, that reservoir bag is starting to fill, but we're going to then begin delivering breaths. I'm going to turn the oxygen off for demonstration purposes, but just know on an actual call or an actual patient, that would remain on. So, delivering a breath and maintaining a good seal on an actual patient with just one person is very difficult to do in the field. The best technique that I could tell you would be the EC. So you have this E with your fingers, and you have the C with your fingers. Your C goes on top, and then your E is going to go on the jaw and pull that face. You're pulling the face into the mask and pushing down up here. And then when you deliver a breath, basically just want to make sure that chest is rising and no air is coming out of that mask seal that you have. In the field, what we typically tend to do a lot is one person will hold the seal with 2 hands while our partner is delivering a breath with the BVM. When delivering a breath, these new BVMs that have come out, you guys might see bigger BVMs wherever you work or you might end up working. Are typically about 1,000 cc's. This BVM right here is about 500 to 600. This is perfect amount for our lungs. The bigger BVMs, people tend to get nervous and they will squeeze the entire bag. we've actually overpressurized that thoracic cavity. We've injured lungs. We put too much pressure on the heart. So we've actually worked against ourselves. When giving a breath, it's smooth, it's controlled. I like to do underhand because this feels awkward for me. And now I actually have to focus on what I'm doing. Instead of this is so natural, I can look and do so many other things. I know I'm squeezing the bag just fine, and I'm not actually evaluating what I'm doing. Right, so I slow down, I take some deep breaths myself before I give some deep breaths to my patient. I'm gonna look at their chest. And as soon as that chest rises, I know I no longer need to continue to squeeze the bag and overinflate their lungs. See that chest rise? I might hold it for a second. Okay, so when delivering a breath, you're gonna deliver a breath over a full second. So 1,000. And we typically give one breath every 5 to 6 seconds for 10 to 12 breaths per minute. One thing that's very easy to do and something we see a lot, especially in the field and in testing, is students or newer EMTs will 1,000, 2, 1,000, 3, 1,000, 4, 1,000. And they're not actually counting, they're over ventilating the patient. So I know you're nervous, I'm nervous, patient's family's nervous, but you've got to be that calming effect on the call. Take a deep breath. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6. It's just like that. It seems like it's taking very long to deliver a breath, but this way we're actually ventilating our patient and oxygenating our patient, allowing for circulation, allowing for, maybe we're doing CPR. But if we over-oxygenate our patient, there's no gas exchange. There's no carbon dioxide that's actually going to circulate in the body as well, which is what we need to keep our patient alive. So it is very, very important for you to be giving one breath every 5 to 6 seconds. Okay guys, now we're gonna go over some ILS airway interventions and some ALS airway interventions and how you as an EMT basic could assist your partner. So typically how these go is we get on scene, the medic is going to be doing an IV and medications while you as an EMT basic might be at the airway, you've placed your NPA, you've placed your OPA, and you're bagging your patient, okay? The medic has done their medicine and now they want to take over the airway because it's a lot safer to do intubation or like a supraglottic airway. So the choices we have for the supraglottic airway are things like this. This is called an LMA. This is a blind insertion. So if you're an EMT advanced, you could do this, or if you're a paramedic, you could do this. Basically, we would pull this OPA and we would place this in the oropharynx. We blow it up, so this is going to inflate. This cuff right here will inflate and basically go over the esophagus, so this way we're only getting air into the trachea. This helps a lot with preventing our patient from vomiting. We also have something like this called a King airway. Again, blind insertion, we place it and we blow it up. Same with this. This is called an iGel. These are all ILS airways or supraglottic airways, blind insertions, we place it. And this gives us a lot of protection. These are a lot of paramedics go to because they don't have to focus too much. They can just place it and we're already maintaining the airway a lot better than what we were. So Chris here and I will demonstrate what this would look like on a call. If I'm the EMT basic, I have my NPA in, I have my OPA in. I'm bagging my patient. Once Chris is ready to place the airway adjunct, his LMA, inside the patient's oropharynx, he's going to let me know. And I'm going to take the BVM off. I'm going to remove the OPA. I'm okay to leave my NPA. And then I'm going to actually remove the mask from my BVM. With this BVM, it's actually going to sit on top of the LMA. And that's how we're going to deliver breaths. So this is what it would look like. All right, Chris, you just tell me when you're ready.
All right, we'll give it one more breath, and then we'll have you pull out the OPA, and I will place the LMA.
Copy that. Here's my last breath. OPA is out. All right, I'm taking off the mask. My BVM, I'm going to keep this in my hand. For some reason, this doesn't work. I can quickly reattach it. My NPA is still there, and I can begin breathing. Okay, Chris has it placed. I'm going to place my BVM on top, and now I'm going to give a breath. You'll notice Chris is not letting go of that LMA. We don't want to let go of that LMA until it is secured. So once we lose that, we're basically starting from ground zero again. But again, I'm still giving one breath every 5 to 6 seconds. Chris is now making sure this airway isn't going to be moving anymore. And as a BLS provider, I'm not the one who inserted it, but I can absolutely be the one ventilating this patient.
All right, so we'll check the stomach. Give me a breath. Confirm that there's no air in the stomach. Then we're going to check the lungs. Breath for me. And breathe again. Confirm that we have good airway sounds. And continue to ventilate one breath every 5 to 6 seconds.
Copy that. Again, I can continue ventilating this patient while Chris does other paramedic stuff to help out our patient. Okay, another means of managing the airway we're going to talk about would be an ALS procedure. It's going to be intubating the patient. Again, this is a paramedic scope procedure. As an EMT basic though, this is something I'd be expected to assist with. Whether I'm setting it up, I'm getting all of Chris's tools out so he can do it, or I'm here managing the airway, and once he's ready for me to help him, I'm going to help him. So this is the best way to secure a patient's airway. This is our ET tube and endotracheal tube. As you see, it's much smaller than our LMA. This is going to go directly into the trachea. That trachea opening is very, very small. Chris is going to have to open the airway, use this we call a blade. It's got a flashlight on the end. He's actually going to go into the airway, open and bring this lower airway up, find that tracheal opening, and place his tube inside of that tracheal opening. As you can see here in the top, we call a stylet. This keeps that tube rigid so it's not flopping around in the airway. Once Chris gets the tube set into the trachea, he might say, Cody, pull the stylet, and I'll be expected to now pull this out. Okay. Again, Chris is then going to inflate this cuff on the bottom, and that is going to keep that tube right in the right place. Again, we're going to have to secure it, but we'll kind of show you what this would look like on an actual call. So again, I'm the EMT basic. I've got my OPA in, I got my NPA in. I'm managing the airway. Chris has been doing his paramedic skills this whole time, getting an IV, maybe getting an IO, giving medications. Now he's ready to take over the airway. Say, all right, Chris, I got an OPA in. We got good compliance. You just let me know when you want me to pull the OPA.
Cool. So for this to be successful, one of the things that we want to do is make sure we have all our equipment set up, like Cody said. If your partner asks you to do that, if it's a partner you've worked with before, you might know how they like things, because we can be prima donnas a little bit sometimes as paramedics about how we like our things set up. But if not, the general stuff you're going to want to do, like Cody said, make sure you have an ET tube set up. There are different sizes of ET tubes. So it's not a bad idea to ask your partner what size. The sizes are going to be based off the patient size. We're using a 6.0 because that's what we use for the mannequins. But 7.0, 7.5 is probably what we are typically going to go for. 7.5 or above is preferred by the hospital, because if it's a 7.0 or below, there are certain things they can't use that for. So they like a 7.5 or above. But just go off what your partner says if they have a special request as far as sizes go. Obviously, pediatrics are going to be much smaller. Adults are going to be bigger sizes. Like Cody said, we're going to make sure that we have the stylet all placed before we go. We want to confirm that this little bulb didn't get punctured or anything. So before we do this, if you're setting things up, we just want to fill it and make sure that this will stay nice and secure. And that's usually about 10 cc's of air. So we need a 10 cc syringe here with no fluids or anything in it. It's just going to be air we're going to push in. We'll also take our blade. There are different actual blades. The handles are going to be all the same. The blades are going to be a little bit different. So again, your partner should tell you what blade they want. There's the Millers and the Macintosh, or the Mac. The adult sizes are like a 2, 3, 4, depending on which blade. So I would tell Cody, can you set me up with a Mac 3? That would be a Macintosh 3. I remember Macintosh is the curved blade because it's like a Macintosh apple, and apples are curved. That's how I remember it. However you remember it is fine. But just ask your partner what blade selection they would like, because again, we're prima donnas. And so we're very particular. I prefer Macintosh blades. Some people prefer Miller. And you might have what's called a glidoscope or some sort of video laryngoscope. And again, they'll be able to tell you what size blade that they want. I also like to have the securing device. This is a Thomas tube holder that we're using here, but there's a number of different ways to secure the ET tube. I like to have that in place beforehand. This way, if we have a successful intubation, I'm not having to manually hold that a long time as we're manipulating the neck to get this stuff in place. So if you don't prepare, you're preparing to fail, whatever little saying you want to remember. I like to have all this set up beforehand so this goes really smoothly. So like Cody said, you might just be out here on the airway and I might be doing all these things. Or I might be doing medications and have a firefighter or somebody else doing this and asking my partner to set up my intubation supply. So make sure you're aware of those things. So we have everything set up here. I'm going to do a little bit more lube just to make sure that we're all set there while Cody does this, and then we will be ready for the procedure. All right, so we are always going to want to pre-oxygenate our patients and make sure we get some good breaths in beforehand. That doesn't necessarily mean their SpO2 is going to be high, but we will make sure that we are giving some breaths beforehand. One other thing to check, there should be a light on the intubation blade. We like to say it's light, tight, and bright. So when you close it, that light should turn on, and there shouldn't be much play in this. If there is play, then you're going to need to change out and get some different equipment. So I'm already here. Cody, again, will have you give one more good breath, and then you'll pull that out, pull the OPA out, and we'll go for the intubation.
Copy that. Give my last breath right now. OPA is out.
So I'm going to come here.
Again, I'm taking the mask off, but I'm going to leave it in my hand. I have my NPA still in place. So if he misses the tube, I can quickly reattach this. Looks like he's got it.
Go ahead and pull the stylet.
Okay, I'm going to pull your stylet.
You can. Next, we're going to place an end-tidal CO2. This is going to be an inline end-tidal CO2. It's something else that you might have ready, and your partner might ask you to put it on. This is going to go between the BVM and the ET tube. And so this is measuring end-tidal CO2. You don't need to worry at the basic level too much about that. Go ahead, yeah, you can go ahead and place it. And what that means, but all you really need to know, this is one of our best confirmation methods to confirm that we are where we want to be, that we're in the trachea and not the esophagus. So this will plug into your cardiac monitor, and if we are in the correct position, we will get a number. That number could be low, it could be high. Normal is 35 to 45, but as long as we don't have a 0, that should mean that we are in the correct place. And so this is one way we can confirm we have a successful intubation.
Again, as an EMT basic, you will not be placing an ET tube. You will not be intubating the patient, but you are expected to assist, pull a stylet, and then bag your patient. This is something you might be stuck on for the entire ambulance ride into the hospital, is now ventilating and controlling this ET tube.
All right, so more confirmation. We're going to come down here and confirm we don't have any air in the lungs. Give me a breath. Nothing there, and we'll check both lungs. Breath, please.
And it's okay
One more.
to give breath after breath in this case, because now we're confirming that we're in the lungs. I don't have to wait 5 seconds between each one just to confirm that we're actually getting air into the lungs. Okay, another thing you might see as a BLS assistant helping out your paramedic is if we have a difficult airway, your medic might use this. It's called a bougie. This is a little bit easier to place in your patient's trachea than the whole entire ET tube. So we'll see a medic still use the blade, lift up that lower airway, place that bougie in, that really small bougie, and I as an EMT basic would be expected to then place this over the bougie. I'm really just following his traces. This is still his skill, this is still his scope. Again, this is something we've talked about, we've pre-planned. He said, hey Cody, you're gonna place this tube over the bougie once I get it set. I said, okay. Chris, you let me know when you want me to pull the OPA.
All right, next breath.
3, 2, 1. Okay, OPA is pulled. Got this ready.
All right, so I'm going to stay here so I can continue to visualize. You go ahead and slide it over for me, please.
Okay, I'm going to place that tube on. Tube coming. I'm basically just bringing it to him.
All right, you hold him from the top?
Yep.
All right. All right, we're good?
And then he'll probably have me pull this bougie, but I'm not going to do it until he tells me to do it. We do not want to lose this airway. So now I'm back to grab my BVM, dropping the mask off. I might place my end tidal. That'll humble you. And now I can begin delivering breaths. You guys can see these lungs fill up so much easier now that that tube is directly going into the trachea, which directly goes to the lungs. So this is going to oxygenate and ventilate our patient so much better than an OPA, NPA, and even an LMA. Another thing you might see in the field as an emergency responder is something called a CPAP, continuous positive airway pressure. Something we use on patients who are having a lot of difficulty breathing. These patients also might be suffering from something called CHF. Typically, CPAPs come in a big machine. Depends on what your agency is carrying. Here where we're at, we carry something like this where we can actually just hook up to an oxygen tube. This is called a BLS CPAP. So what CPAP does is at the bottom of our lungs, we have our alveoli, correct? When we take a breath, we might have so much fluid or we might not be strong enough to get a breath to the bottom of our lungs. So what this does is it takes the breath that you're already taking and just pushes pressure into your breath to make it easier to take a full breath. And it actually allows that alveoli to actually get the oxygen it needs and actually have that gas exchange. So this is just placing pressure. Your patient, if they need this, are in a pretty bad spot. They're really, really sick. They're going to be anxious. They're going to be tripoding. They're going to be talking 2 to 3 word sentences. So the quicker we can get this on, the better. And the more we can talk our patient through this. It is very uncomfortable to have this on your face. Every time you take a breath in, it's going to push air into your mouth, which makes patients very, very nervous. So one thing we'll do, and I'll show you when I place it on Wade, is I'm going to place it on his face. I'm going to give some pressure. I'm going to have him take a couple deep breaths before I secure it, just so he can get used to it. But with these, they're really, really simple. On the other end is just normal oxygen tubing. We're going to place it on our oxygen, and it tells you what to flow it at. So for this one specifically, it's 10 liters per minute. I'm going to place it on my oxygen regulator. Put it at 10. Okay, Wade, I'm going to place this on your face. You're going to take a couple deep breaths just to get used to it, okay? So I'm placing it on his face. I'm going to add some pressure. We want this to be tight. You can hear how loud it is because of how much pressure it's actually giving my patient. I'm going to place the harness on his head. And then I have these clips down low. Again, this is something you're going to have to practice with a lot to get comfortable with. And that's pretty snug. If I want it to be tighter, I can take the straps and adjust. And again, I'm just coaching my patient through this. Good, just keep taking those slow, deep breaths. Okay guys, thanks for watching our BLS Airway Management video. If you have any other questions, please go ahead and look us up online at idahomedicalacademy.com or check out the rest of our YouTube page if you are interested in any of our other videos. Thanks.
Check on the mic.
CC in the house, about to do some ALS and BLS. Okay.